came in with a bullseye rash, and they told you they had been hiking in the woods, you're listening, and it was summertime, and they had on shorts, and the grass was tall, what do you automatically start to think about? Probably Lyme disease, right? We hadn't talked about that yet. But you're listening for cues when your patients are talking. So etiology means what causes a disease. Do you need to learn this whole list of things? No. But we do need to know that or understand sometimes it's a genetic cause, sometimes it's a nutritional deficit, sometimes it's congenital, that means they're born with it, sometimes it's chemical, a toxin, whatever. We need to know what causes it. For example, what causes COVID-19? What causes it? It's that SARS-CoV-2 virus, right? What causes TB? Mycobacterium tuberculosis. That causes that disease. And that's important that we understand that. Now, then we're going to have something like this. Idiopathic. Usually that is on a test somewhere, and it means, you know what? We have no idea what causes that. We don't know. It's idiopathic. We don't know the cause. Iatrogenic means it comes from unwanted or unintended medical treatment. Like they got it in the hospital. Okay, so that's etiology. Another thing that you need to know is we may not know the exact etiology, but we know the risk factors. Y'all know what a risk factor is? It's when a patient is exposed to a certain set of conditions, they're likely to get this disease process. For example, you all are educated in this country about heart disease. Give me some risk factors. You already know them. What are some risk factors for heart disease? Smoking. What else? Obesity. Diet. Lack of exercise. Okay, those are risk factors. Is everybody going to get heart disease? Does everybody that doesn't exercise get heart disease? No. Does everybody that smokes? Those are risk factors, okay? So that's really important too, because we want to be able to teach our patients how to avoid disease. Okay, that's etiology. Patho, we're going to give you the patho of how this disease starts from the very beginning. So that's really going to be important for you guys to know. Signs and symptoms. Let's don't look at the slide. Signs and symptoms. Let's do. A sign is something that's objective. A symptom is subjective. So for example, what is nausea? A sign or a symptom? A symptom. How do I know you're nauseated? Because you tell me. What would be the sign? That you vomited on the floor right here, right? So that would be your sign. So signs are lab values, like Dr. Wright said, learn normal white count. So things that are objective, an x-ray, a white count, what you learned Friday in assessment, you palpate the abdomen. If it's hard, then you know their abdomen's hard. That's a sign. So things you find on your assessment. Those are your clinical manifestations, and you'll really want to pay very close attention to those as you study, and make sure you know the things that differentiate that disease. These terms you need to know. What they mean, again, it's kind of boring because I'm giving you definitions, but you have to because this is our new language. So if something is latent, it means you've been exposed to something. You really are not really sick yet. You might have something on your lab. And then to the very beginning, there's some small little signs and symptoms. Incubation period is the exact same thing, except it's when you've been exposed to a bacteria or a virus or something, and it has to cook a little while before you get sick, right? Like if I had strep throat and I coughed in your face right now, it's going to start incubating, but you're not sick yet, okay? The very first beginning. And then the prodromal period are those first little things that happen that you just can't put your finger on it. I'm tired, I feel like I'm getting sick, that sort of thing. Manifest illness or acute phase is when the signs and symptoms of a disease are at its biggest point. What have I got next? Subclinical. We're going to talk about some things that are subclinical. For example, I could have kidney disease right now, and I could have one kidney completely destroyed already, but the other one's still going. So I'm getting in trouble, but I'm feeling fine, okay? Probably until my other kidney is 90% gone will I notice anything. But things are going on beneath the surface. The same thing with hypertension, right? It's called the silent killer, isn't it? Because the person feels fine and then suddenly they're not fine. So things are going on beneath the surface that you don't really have any acute manifestations of. Y'all know the difference in acute and chronic. Acute, maybe hours, days, weeks. Chronic could be months, years, forever that a disease is happening. Exacerbations and remissions. You need to know that because we're going to be talking about autoimmune diseases. And that means when the body is attacking itself. So an exacerbation is a flare-up, and a remission is when the signs and symptoms kind of go down. We'll be talking about that with lupus, arthritis. People have flare-ups, and then they have times when they're in remission. And so now that you know that, when we start talking about exacerbations and remissions, we won't have to define it again, you'll know. And then if somebody is in remission for 5 years, what do we say? Maybe they might have a cure. Convalescence just means recovering, getting better, taking time to heal. And then sequela is a really interesting thing. It is because you had this disease process, now you've got another something going on. What comes to mind is somebody who had a stroke. Maybe now they've got paralysis. Maybe they're paralyzed now. Maybe they develop a pressure injury because they can't move. Maybe they had COVID-19 and now they've got all these symptoms of what? What's coming out now? The long COVID, all these things that are happening because people had COVID. That would be a sequela. We're going to be talking about, y'all, nurses take care of vulnerable populations. And we need to be thinking about as nurses that not only does etiology matter, but social determinants of health matter when thinking about disease. That means that people with a low education level, they may be more likely to develop a disease process. Why? Maybe because they don't have access or they don't understand how to manage their disease. People who live in extreme poverty, people who live in dangerous neighborhoods, people who don't have good schools. All of these things can affect the health of a patient, of a person as well. All of these things, we're going to be talking about adults mostly, okay? But age does matter, and values are different with ages. Like, for example, if my heart rate right now was 120, that would be too high. For an infant, maybe not so much. So, who do you think is most vulnerable to disease age-wise? The very, very young and the very, very old. Yeah. Gender. There are gender differences, and we'll be talking about them as indicated. You know, certain conditions are more common in women, some are more common in men. Lab values. Hemoglobin and hematocrit, they're different in males and females. Creatinine, a kidney lab. So that will be important for us to know and as we study. Ethnic and genetic background is important. What is a disease most people can think of right off the bat that happens in certain ethnic groups? Sickle cell anemia. Who does that happen to? African Americans. There's another kind of anemia called pernicious anemia. It happens mostly in Scandinavian people. Or maybe there's a disease that happens mostly in a Jewish population. So as nurses, we need to be thinking about that when we know the ethnicities of our patients and that sort of thing. So where we live matters. Are we getting a lot of frostbite here in Alabama? Not that I know of. You know what we're getting? What? Heat stroke. Yeah. Kidney stones. Why? Because we're so dehydrated. We get lots of kidney stones. So where you live matters. Geographic area. The Ebola virus. Democratic Republic of the Congo or something. So, you know, it matters the geographic location. All right. Y'all, certain labs that you draw are going to have different values depending on what time of day you draw them. Okay, treatment we'll talk about. It needs to be evidence-based, meaning that we just don't say, you know what, I think I'm going to try putting a little red pepper flake in their shoe and see if that'll cure arthritis. You know what I'm saying? We want things to come from research and be evidence-based. Okay, y'all do need to know this, okay? So when we talk about health, we talk about levels of prevention. Primary, secondary, and tertiary. Y'all do need to know this. Primary prevention means that you kept that patient, or maybe you didn't. Maybe you did through your education, that you taught them how to not get COVID, and they did what you said, and they didn't get it. That's primary prevention, okay? Flu shot. You get your flu shot, you don't get the flu. Get your measles vaccine, you don't get the measles. That's primary prevention. You didn't get it. You wore your helmet when you went skydiving. So that when you didn't land just right, you didn't fracture your skull, okay, because you had your helmet on. How many people have been skydiving? Nobody. All right. That was primary prevention. All right. Secondary prevention means you caught it. Like we all went and we had a mammogram, and they found something. And we caught it really early. We still got it, didn't we? We still have that, whatever that is there, but it was early screening, okay? That's what secondary is. And then tertiary means we treat it, okay? So prevent, primary, secondary screen, tertiary treat. All right. Going back to high school a little bit, maybe even middle school, we got to talk about the cell, y'all. Because what did you learn about the cell? It is the basic building block of life. Well, it's also the basic building block of disease. And so we're going to learn a little bit. So I'm going to tell you what you need to know about the cell, okay? We're not going terribly deep. Now, this is important. So when you have a cell, they've got jobs to do, okay? And inside that cell are little things called organelles, and they've got jobs to do. And that cell is out there, and that cell doesn't want things to get in that don't need to get in, and it doesn't want things to get out that don't need to get out. So that plasma membrane you see here protects that cell. It's a lipid. What does the word lipid mean? If you didn't know what that meant, what would you do when you were studying? You'd look it up. So it's a double lipid bilayer, bi means two, and it keeps water-soluble things from getting in that cell and damaging it. So tries to keep bad things out, but it lets lipid-soluble things in, things like oxygen, certain hormones, and that sort of thing. And so it's a very protective thing for the cell. So that can get damaged, and we'll be talking about that. And then proteins are also on that layer. And they can open up little channels if they need to let things in. Or they may have specific jobs. The proteins have really a lot of jobs on a membrane, okay? The little proteins on a red blood cell make it be able to squeeze and get through a capillary without rupturing. So proteins have a lot of jobs on that in the cell, okay? This one right here, the proteins here, what they're doing is they're really opening up and letting things like these sugar molecules get into the cells. Y'all remember phagocytosis and all that? Well, this is a picture of it, okay? The cells need for big things to get in sometimes. So they grab it, membrane, and pull it in. Something you know is phagocytosis. We need it for phagocytosis. White blood cells, what do? They grab in that bacteria and break it down, okay? So we cannot get an infection. Small particles that need to get in, cellular drinking, pinocytosis. This is another way things get into the cell. All right, so did y'all know we need cholesterol? It's part of our cells use it. And it travels around in this little capsule here called low-density lipoprotein, okay, LDL. Don't worry about that. We're going to learn about it in cardiac until you hate me for it. But so we have these little receptors on the cell, and they grab that LDL and they bring it in, and they break it down. They get that coating off, and we use that protein, and then those little receptors go back up and grab some more. Y'all, there's some people that don't have enough receptors for LDL on their cells. So what do you think about their cholesterol level in their blood? Think it's high or low? It's high. Because they're not being able to bring it into the cell. And so these are people that have familial high cholesterol because they're not able to use that cholesterol. What about this one? What do we need in our cell? We need glucose, don't we? Well, guess what? We have a receptor, and insulin plugs into it, and it's like a key. It's like a key. And it unlocks these little things here, these proteins that grab the glucose and bring it in. What if we don't have any insulin, as in somebody with type 1 diabetes? Can that sugar get into the cell? No. So do you think they have a high or low blood sugar? High blood sugar, because that sugar can't get into the cell. So see how all these little things matter? All these little proteins on your cell membrane, on your cells, they matter because they help us with the cellular functions. If we have too much stuff getting into the cell, it swells. Another word for swelling is edema. If you didn't know that edema meant swelling when you were studying, you would look it up, wouldn't you? Because we might use the word swelling on the test instead of edema, or we might use the word edema instead of swelling. So always look up the words. And then cells shrink if too much stuff gets out. Okay, the sodium and potassium pump, the moment you've all been waiting for. Y'all, this is so important. So this is something you need to write down and never forget. You've got sodium and potassium. What we want more of inside the cell is potassium. And we want more sodium outside the cell. And so we've got this pump called the sodium and potassium pump, And it takes a lot of energy, or what's another word for energy? What's the units that we spend as energy? ATP. Needs a lot of ATP. About a third of our energy of our cells runs this pump, okay? It's pumping. If too much sodium is inside the cell, instead of potassium, what do you think is going to happen? Do I have it up here? Yeah, I do. Dang. Okay. Think about yourself. What happens to you when you eat a lot of salt? You're thirsty, aren't you? All right, that cell, if it's got a lot of salt in it, it's going to be trying to pull what in? Water. It's thirsty. So that cell is going to swell, and it could burst. Okay? That cell would die, wouldn't it, if it burst? So do we need that sodium and potassium pump working? Absolutely. And what does it take to work it? Energy. And how does the cell get its energy? We're going to be talking about it. It's got to have oxygen. Okay? All of these, y'all, this sodium and potassium pump, we're going to talk about it with heart disease. What if I have no blood flow to my brain, and my sodium and potassium and calcium pumps fail in my brain? What's my brain going to do? It's going to swell. Remember? Swelling. That failure of that sodium and potassium pump causes swelling. What happens if my brain swells? Y'all, I'm going to die if we don't do something about it. Okay? So that swelling is important. So where do we want the sodium to be? And we want potassium inside. That is a concept. You can't forget it, okay? Okay. 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 Y'all talk back to me. All right, holler back. All right, so here's that pump right here. It's pumping. Y'all, what does extracellular mean? Outside. Look at it. It's pumping the sodium out, 3 of them, pulling the potassium, which is K, in, okay? And this is a protein, that pump. Mitochondria, what y'all learn? They're the what? They still are. They still are. So here they are, and they're working to make energy for that cell. So this is what I need y'all to know about this slide. It is a boring slide, isn't it? But it's good. Because what did we say we need for that sodium and potassium pump to work? Energy. Where do we get it? We need oxygen to make it. Here we go. Oxygen. We've got glucose comes in, and we make little 2 ATPs, and that becomes pyruvic acid. You don't have to know this, y'all. It goes into the mitochondria, and in the presence of oxygen, which is aerobic metabolism, we make 34 ATPs. 34. But our body is miraculous, and we can have a certain amount of metabolism without oxygen, or low oxygen. That's called anaerobic metabolism. But look, it only makes not much, okay? So the whole moral of this story, you make more energy with oxygen. But your body can compensate with anaerobic metabolism to make some ATP. What if we don't have any oxygen at all? Y'all pretend like none of us had oxygen right now. We're going to die, okay? Mitochondria, what do we need to know about this? You don't have to memorize this whole slide, okay? But free radicals can damage our cells. Free radicals they're a free electron racing around, but what they are is bad things like radiation, pollution, cigarette smoke. All of these type of things can damage our cells, all right? And they oxidize. And so some people take antioxidants, right, for that reason. So these vitamins here, A, E, C, beta carotene, chocolate, are antioxidants. And so they combat the bad stuff from the free radicals. What do you need to know about lysosomes? They break down stuff, right? So when we bring things into the cell, like that LDL, it can be broken down to use. Sometimes when your cells die, the lysosomes do what's called autolysis, and they break down the cell. Y'all, this is a great concept. Do you know why we draw lab work sometimes? When I say draw lab work, what am I talking about? What am I talking about when I say that? Put a tourniquet on my arm, get a needle, and draw some blood out. That's lab work. So different labs tell you about different body parts that might be damaged. So if I have a heart attack, what kind of cells are going to die? Heart cells, okay? They're going to die, and they're going to autolyse, and they're going to release their contents out into the bloodstream. And so now I come into the hospital with a heart attack, and you draw my labs, and those specific cardiac enzymes are released, I can tell I had a heart attack. So CPK, all these enzymes are going to be released. If my pancreas is damaged, I'm going to have a high amylase. If my liver is damaged, I'm going to have high, liver enzymes. So specific to that cell, that's how we can draw labs and tell what organ has been affected. AST, that's the liver enzyme. You don't have to know that. Not yet. Ribosomes are protein synthesis. That's all we need to know about that. And why is that important? Because we said the proteins have huge functions on this within the cell. They have all kinds of jobs. And then who tells everybody what to do? The nucleus. So that's all we're going to say about that, okay? Now, we're going to talk about cellular injury and adaptation. So we talked about things that our cells need, that plasma membrane and all that business. But let's talk about what cells do when they get injured. The first thing we want to think about, so your body has to react to stressors in the internal and external environment. And we're always trying to get back to a set point, like I need my vital signs to be stable. You know, I need my heart rate to be this. I need my body temperature to be this. So if I go outside right now, wearing this, and it's 0 degrees outside, more than just me putting a coat on, I might start shivering, right? Because my body's trying to get my temperature up to a normal range. So your body is always trying to adjust to stressors to maintain homeostasis, to maintain a set point. So our body adapts. What do you think happens if it doesn't adapt? We get sick, right? If we're not able to adapt, we can get sick. So that's all we're going to say about homeostasis. Y'all need to learn these terms, okay? Etiology we know. Histology, we're looking at cells under a microscope. We got those cells from a biopsy. We went and got a little piece of tissue. And pathognomonic changes mean, man, yeah, I'm looking in the microscope, those certain changes on that cell, that's indicative of sickle cell. So I know that they have that. So that's what that means. But our cells can, with repeated stress, begin to adapt. And those adaptations can be reversible if that stressor is removed, or they can be permanent. So let's look at some of those things that we're talking about. You could use this one slide right here probably to take all your notes on these things that we're about to talk about. Cellular changes. The word atrophy, you already might know what that means. If our cells atrophy, they get smaller from all kinds of reasons. Maybe, who's ever had a cast on their arm or leg? And when you took it off, did your arm look kind of skinnier or smaller? It atrophied because of lack of use. You know, or things can atrophy because of lack of nutrients, but it means that they get smaller. And aging, typically, the older we get, everything tends to atrophy or get a little bit smaller, except your heart, it tends to enlarge. But all of these things can cause cellular atrophy. So, if I had a cast on my leg, and my leg was really super skinny now, and then I started walking again, did everybody's arm stay little, or did it get back to the right size? Right size, because what happened? It was reversible injury, wasn't it? It was reversible because we started using it again. All right? So that was okay. Let's look at this one. Hypertrophy gets bigger. Gets bigger. And so there are two kinds. This kind, physiologic, is this guy. Does he want that to happen on purpose? You better believe it. Okay? All those people in the Olympics, oh my word. I was looking at Simone Biles. That thing is tight. Her muscles are what? They're hypertrophied, aren't they? Did fine. That is physiologic. She worked hard for that. That girl deserved it. But look, pathologic hypertrophy. If my heart has to work too hard for years because of hypertension, it's going to enlarge, but not in a good way. It's not going to have collateral circulation. It's going to be ischemic. That is bad hypertrophy, okay? Getting larger. But what if I got my blood pressure? Well, now let's think about this guy. What's going to happen to him if he quits that? Is he going to stay like that? No. All right, so this is pathological hypertrophy. Well, this is good here. Look at all. When I say collateral circulation, this is what I mean. Growing new vessels from just working out, running, walking, or whatever. This is hypertrophy, all sloppy and not many vessels, kind of ischemic, which means lack of blood flow, probably from high blood pressure, right? Is much blood going to be held in that little spot? No. So that's bad hypertrophy. Hyperplasia means too many cells, lots of cells. It can be good or bad. Pregnancy is an example up here. If I go to Colorado where it's really high altitude, there's not as much oxygen, is it? What do you think my body's going to do? Because it knows. I'm going to make more red blood cells. My red blood cells are going to increase because they're like, okay, there's not much oxygen there. Let me get a whole bunch of red blood cells to carry what we can get. And then when I get back to Alabama, you know what happens? They die. I don't need them anymore, and they're gone. That's a good type of hyperplasia. A bad type might be this keloid here on this scar, where the skin cells, they started, healing and multiplying, but they got overboard, and it made that big raised scar there. That would be a bad example of hyperplasia. Meta means change. The cells changed from one kind to another. That might not be good, huh? Typically from inflammation. So let's take an example here of GERD. Y'all know what that stands for? Gastroesophageal reflux disease. It means that the acid in your stomach is kind of refluxing or going back up into your esophagus. Some of you may have it. Some of you may have it by the end of the semester. Some of you may have it if you eat the wrong thing, okay? But you know what happens over time? The cells in the esophagus, they start changing. You know what cells they start changing into? Stomach-type cells. Because those stomach cells can handle that acid, okay? So they start changing to be able to adapt to that acidic environment. Does that make sense to y'all? So here's all that acid. Woo, I just ate, well, I don't know what I ate to make all that, whatever you eat that makes your stomach hurt. And all that reflux goes back up in there. So if this is going to be reversible, I'm going to have to take the source away, aren't I? So what can I do? How do people sleep who have GERD? What do we tell them? Elevate the head of the bed, right? What else do we tell them to do? If you ate at Foosackles and you got the bigger food and it upsets your stomach every time, maybe that's your trigger, right? So don't eat that. Or take some Tums. Get rid of the cause, and then guess what happens to the cells? Hopefully they change back into the right kind of cells, esophageal cells, right? That is a reversible adaptation. Sometimes they don't reverse. When the esophageal cells stay like stomach cells, that's called Barrett's esophagus. And that is a condition that we monitor very closely because it can turn into esophageal cancer. So this is something that we watch very closely. Dysplasia. Abnormal. Abnormal growth. We're starting to get serious here. We're starting to think pre-cancer, okay? The cells are changing, and like these are normal cervical cells. Look at these. They're not cancer yet, but they're getting suspicious, okay? We got to watch them. And then the neo means what? New. There's that singer guy that's named Neo. And so neoplasia is new growth. And it usually is, well, actually new growth can be benign or malignant, and we'll be talking about that. All right, so y'all know all the adaptations. Let's talk about, remember I said if I had too many red blood cells, what happens? If I went to Colorado and then I came back home, what happens to them? They die. But it's not a nasty, terrible, disgusting, inflammatory, horrible death. It's planned. It's very neat and tidy. All the debris is swept up. I don't have an inflammatory process. I'm not sick. That's called apoptosis. That word means a falling away. It's clean, it's tidy, it's planned. Apoptosis. And it's not reversible. Those red blood cells aren't going to come back, but that was supposed to happen. On the other hand, necrosis is bad. It is cells that die like those heart cells I said. They're just spilling all that content out into the bloodstream. They're causing inflammation, sickness. That is a bad kind of cell death, is necrosis. So you have some that is planned and some that is not good. Okay, well, here I am again on that sodium and potassium pump. We got to talk about swelling, which we already did. Does it make sense to y'all that those cells swell? What's another word for swelling? Okay. Tell me again why those cells swell if the sodium and potassium pump fails. Because sodium is where? Inside the cell. And what follows sodium? Water. And what happens when all that? Swelling. And if it swells too much, the cell can burst and die. Perfect. Perfect. And here's a little word for you. Things that are swollen are megaly. So if I have hepatomegaly, what's swollen? Hepatomegaly. Hepato means liver. My liver's swollen. What if I have splenomegaly? My spleen swollen. What if I have cardiomegaly? My heart. So megaly, think about it on Shark Week, there's always megalodon. It's a really big shark. So megaly, swollen, big. Another pump that we have is the calcium pump. And, you know, if calcium accumulates in cells, they can die eventually. And so that's what you see on a mammogram, is sometimes it's calcium deposits. This is if the plasma membrane loses its integrity. Things can go in that don't need to get in. Things can get out that don't need to get out. Other things that can cause cell injury is, or cell adaptations, is something happens with the protein synthesis. What do we say about proteins? Very important to cellular function. So if our protein factories are in trouble, then our cells are going to be in trouble. Genetic damage can happen from things like this, where our DNA is damaged from tanning beds, etc., and can cause changes. What kind of disease does this person have? Jaundice is a sign of what? Liver disease, or either that or breaking down of too many red blood cells. So this is an example of cellular injury from intracellular accumulations. We've accumulated too much, in this case, bilirubin. Okay? And so that leads us to believe I need to investigate a little bit further here, because something could be going on with the liver, or they're breaking down red blood cells. So it could be things that you get from the environment, like this. Like if somebody worked in a coal mine, they may have accumulations of, cause coal miners lung. Or fatty liver. Do y'all know what causes fatty liver? What's a risk factor? Drinking lots of alcohol. Okay, it damages the hepatocytes, the liver cells that are responsible for metabolizing lipids. And so the person develops fatty liver. Okay, fat accumulates. What's the answer to this one? So the man went to a health fair, they checked his blood sugar, and they told him it was high. Is that primary, secondary, or tertiary? Secondary. Why? Because secondary means screening. Very good. All right, so let's talk about some things that, I'll try to do this one kind of fast. Some things that cause our cells to be injured. I've already told you one thing, a very common thing. I said the word ischemia early. Did anybody notice I said that word? If you had ischemia, you didn't, do y'all know what that means? We're going to learn, because we're going to talk about ischemia a lot this semester. What do you think hypoxia means, or hypoxic injury? Lack of oxygen, low oxygen, very good. See how we're learning a new language. Chemical things can happen. So we'll talk about some things that can cause our cells to be damaged. Y'all, hypoxia is oxygen deprivation. What do you think hypoxemia means? What does the word emia mean? The ending of emia. Bloodstream. Hypoxemia means not enough oxygen in the bloodstream. Okay? So hypoxia, or lack of oxygen, causes our cells to be damaged. We already know one reason. What does it take to run that sodium and potassium pump she won't shut up about? Energy. How do we make that energy really efficient in the mitochondria? With what? Oxygen. What kind of metabolism is that called? Aerobic. How many ATPs does it make? Woo, y'all are listening. Okay, good. Speaking of that, nobody's asleep today. Well, one, I've seen that. Y'all, do not stay up all night studying for your exams. Do not do it. Because you're going to come in here at 7:30. Those of you who are nervous about being late are going to be here at 7. And you're going to take your exam And then if you stayed up all night, what are you going to do in class? You're going to sleep. Are you going to take notes when you're asleep? No. Are you going to get anything out of class? No. And it's going to set a vicious cycle loop going for not doing well on the next test. So how do you study for Patho? Every day. Y'all, every day. I'm telling you every day, say it every day. Say it every day. So look, by the time next week happens when Dr. Wright's teaching and she's talking about whatever she's talking about, I forgot. I think it's blood cell disorders and things like that. I should be able to tear in here, surprise you, and give you a test on all the material that we have for today, and you're ready. You should always come to the next week already have studying what we went over this week. I know what y'all are thinking. Not me. Not me. That don't apply to me. I can always study the night before. Girl, I know you're not talking to me. I am. And you're going to come see me in my office. You have to study every day. Okay? So count the slides, which there's probably 100, and say, how many do I need to cover every day to be done by next week? If you'll break it down like that, my favorite saying is you can eat an elephant. You can. Can you eat him tonight? Can we all sit down and eat an elephant tonight, Roll Tide? No. But can we eat him in small bites over time? We can, okay? This is an elephant, and you need to eat him. You cannot eat him in one night, okay? Small bites. Y'all promise? Please promise, because I want you to do well, and I want you to start off right. Okay, so lack of oxygen causes damage. Free radicals cause damage. Y'all you don't have to memorize this slide, but doesn't it make sense that if I shoot you, you're going to have damage? So if I stab you or something, frostbite, sunburn, all that mess causes damage. But y'all, hypertension causes damage to your cells. Damages your endothelial lining that we're going to talk about. Y'all, people with diabetes, you're going to learn so much about diabetes, but hyperglycemia, that word, hyperglycemia, means too much sugar in your blood. It is damaging every organ. It is damaging the lining of your arteries. Do y'all know that diabetes and hypertension can cause blindness? Yes, because it's damaging the retinal arteries. Kidney disease. Most people on dialysis, you know why they're on dialysis? Either from hypertension, diabetes, or both. People are getting their legs amputated because of what? Diabetes, that high blood sugar, y'all, that's damaging cells. Okay? Drugs, carbon monoxide, all of these things can cause injury. We know bacteria can, don't we? And viruses and fungus among us, and all that can cause disease. We talked about autoimmune diseases. I said that word. What is autoimmune? Self. An autoimmune disease means your body is attacking itself. Rheumatoid arthritis is an autoimmune disease. That's all you need to know right now is autoimmune means your body's attacking itself. We can have genetic defects. We can have nutritional defects. We can be overnourished or undernourished, and that causes defects to our cells, and we'll be talking about those things. And if you don't eat a balanced diet, if you don't get the nutrition you need, some nutritionists say you need a vitamin every day, but you should be able to get it if you eat a well-rounded diet. I know what time it is. We're going to talk about this endothelial lining real quick. What's the largest organ in your body? The skin. Well, your book says, well, it is. But really, you could almost consider this endothelial layer the largest thing because it lines your arteries. It is the lining of your arteries. And we don't want it damaged. We don't. What do you think we want inside those arteries? Smooth or rough? Smooth. free, flowing, no damage, okay? That's what we want. But if that thing gets damaged, did y'all know the endothelial lining of your arteries is a busy thing? Our arteries can dilate when they need to, vasodilate. You don't have to learn what causes it to vasodilate, nitric oxide and all that stuff. They can constrict when they need to, like if I'm bleeding out, if I'm hemorrhaging, I just cut my leg off and I'm hemorrhaging. You know what my body's going to do? Vasoconstrict to try to keep my blood pressure up. So it can secrete growth factor to make me grow new vessels. My endothelial lining is precious and important, but it can be damaged, okay? Now, what did we say can damage it? Hypertension, free radicals, cigarettes, high blood sugar, hyperlipidemia sets the stage for blockage from atherosclerosis. Okay, so what is in our blood matters. Okay, this is an endothelial lining that's damaged with cholesterol. And it's depositing, platelets are sticking to it, and now I've got a big old clot right here. And this is in my leg. Am I getting good blood flow to my feet? No. What if that's in my heart, my coronary artery? Am I getting good blood flow to my heart? No. So damage to that endothelial lining sets the stage for so many diseases we're going to talk about this semester. Diabetes, hypertension, heart disease, strokes, all of these things are important for us to think about. Oh, y'all look at there. I've already talked about apoptosis and necrosis. Y'all remember which one's planned?
Apoptosis.
Good. Necrosis?
Not planned.
Not so good. There's just a picture of that. So I told y'all I like lots of pictures. You don't have to worry about these two slides, okay? But it's, people say, well, maybe the prostate didn't listen and apoptosis failed and now they've got an enlarged prostate gland. So that could happen. Y'all, is that reversible? Y'all, that's necrosis, okay? This is probably, you know what this is probably from right here? That clogged up artery that I just showed you. That foot's not getting any blood flow. Or maybe they've got diabetes, okay? Those toes are about to fall off. The finger did. And then all of this is necrotic, okay? From ischemia. We hadn't talked about that. I've said it. What is ischemia? Y'all got to know what that word means. Ischemia. Who said it? No blood flow. Lack of blood flow. Ischemia. Who brings the oxygen to the tissues? The blood. Ischemia is going to cause hypoxemia. So lack of blood flow, ischemia. If I have a heart attack, that's from ischemia. Lack of blood flow to my heart. I'm trying to get to a good stopping point. I know nobody has said you needed a break, so maybe you don't. Anybody gonna say it? She said it. Okay, what's your name? Alexa. Alexa, do we need a break? That's like the... okay, what's the answer here? Irreversible inflammatory response. Necrosis. Okay, y'all take a break. Wait, let me see. What time? Alexa, what time do we come back? 11:13. 11:13.
I need to pee. Me too.
Oh, wait for you.
Oh, thank you.
Mommy, a little oil. The necklace is so cute.
Oh, thank you. It's a little bee.
Oh my gosh, it's a real bee.
Allergic to bees, which is kind of funny. Oh.
In 40s, okay? He talked about trying to get to homeostasis and all that business. And so he talked about stressors and how our body adapts. And he came up with that general adaptation syndrome. Do y'all remember that? What kind of response is that? The fight or flight. Is that good for our bodies? Can it be? Is there ever a time when every one of us needs to get up and get out of here? Quick. Yes. Yes. We need that fight or flight response. But there are some things that have to happen with that response so we don't get sick. So let's look. Well, let's talk about this. Our patients are under stress. Your patient's about to go back to surgery in about an hour, and they're in the holding room back there. What maybe could you do as the nurse to relieve some of that stress? They said, I am so scared, nurse. I don't want to be back here by myself. I'm terrified. It's cold back here, nurse. Number one, if I'm cold, great. Go get me an extra blanket. Get it out of that warmer. Have y'all ever had that? Woo. But what if they said they're afraid of being alone? Who could you call back to sit with them? Their family, right? Unless their family is stressful to them. They say, keep my daughter out of here. Then you want to listen to your patient and get them what they need. If it's only a blanket, fine. If it's the family they need, fine. Can the family go back to the operating room? No. They're asleep, they won't know it anymore. All right, you do need to pay attention to the stress response because we're going to talk about it a lot this semester. But you've got your hypothalamus is in your brain, and it's monitoring always to stresses to your internal and external environment, right? Because we want to maintain homeostasis. So say we do have a stressor that happens. Our sympathetic nervous system is going to kick in, y'all. And what's it going to do? What happens to your heart rate when your sympathetic nervous system kicks in? There, a terrible, terrible, terrible person came in back there. It was Albie, because I'm an Alabama fan. Albie came back there and scared us, and so we needed to get out of here. So what would our heart rate do? Go up. What would our blood pressure do? Go up. What would our respiratory rate do? What would my digestive system do? It calmed down. I'm not worried about digestive food when I'm getting out of here. What about my pupils? They're going to dilate so I can see better to get out of here. So that's my stress response, sympathetic nervous system, catecholamines kicking in, norepinephrine. And then sometimes our adrenal glands get involved and they start making cortisol and they start making aldosterone that helps me hold on to sodium in water and gets my blood pressure up. And epinephrine happens that increases our heart rate. But have you ever heard of people that say they're so stressed that they got sick? If you stay in that fight all the time, that fight response, it can make you sick. It could even make your immune system be suppressed. Okay, so here's our fight stage, or flight, if we need to get out. So sympathetic nervous system, adrenal gland, central nervous system kicks in. And then what needs to happen, though? What needs to happen? Can you stay like that? It needs to be time limited. Okay? So we need to start calming down a little bit. Resistance stage. This is what he came up with. This is a great slide. Really, the main thing you need to know about this slide is what we just talked about. If your sympathetic nervous system kicks in, typically stuff speeds up. Parasympathetic nervous system, cholinergic system brings everything back down. Those balance each other. Then, if our level of stress stays up, it just stays up. Have y'all ever been so stressed to the point that you were exhausted and you got sick? Your body can actually get sick. So sustained, overwhelming stress can cause people to get physically sick. What is a stressor? This is kind of a hard question, even though it looks easy. It's kind of hard. What is a stressor? an actual stressor? What do y'all think? Just say it. It doesn't matter if it's wrong.
See?
C, running in the dark. Is it? Do y'all run in the dark ever? No. Nobody?
Sometimes.
Okay.
I mean, oh yeah, definitely.
So when I'm in shape like
First
I'm
thing in the
supposed to be
morning?
and I'm running, I like to run at night. And most of the time, I'm fine and I don't fall. But that time I ran into that garbage can and did fall and tumble, that was a stressor. But just because I was running in the dark, is that a stressor? Okay, so let's cross that. I'm gonna cross that one out.
Say
And that's
D
what you
because
do
of
when you take these
Castle
tests, y'all. Cross stuff out. Cross it out. Okay.
Yelling at me all the time. B?
B, because I have actually been exposed to air pollution. That's gonna start working on me, isn't it? I shouldn't use a cell phone while driving. Do you have a wreck every time? Or you might be going to? Yeah. The other theorist that came along in the 90s said, whoa, no. Wait just a minute. Let me think about this cellular business. This is the 1990s, which is now not the 1990s anymore. What do you think about our stress level compared to the 30s and 40s? Y'all, people used to go to work and they clocked out. I don't feel like I ever clock out because of email. And somebody texting me every 5 minutes. And somebody, I mean, are you always available, do you feel like, or you feel like you need to be? Number one, you tell those people that you can't because in Patho and skills, you're not going to be on your phone. But what about the crime and when I was in college, I never joined an organization that would keep me safe walking to my car. And now, do we think about it walking to our car sometimes? We live in a very stressful environment. Social media stresses me out because I get notifications. Y'all, if there's a tidal wave in Timbuktu, I'm going to get a notification on my phone. And now I got to worry about that. You know, when that submarine sank not too long ago, y'all remember that horrible thing? We were worried about those people being on the bottom of the ocean. Y'all remember that one? I'm worried about those folks. So we're stressed. So this guy came up with okay, maybe we don't have a set point. Maybe we can't get to homeostasis normal. Maybe we have different set points. So he just said it's a little bit more complicated than what Selye said. So he's just talking about all of these continual stressors that we have can overload us, and the end result is the same. We can get sick. So what can we do about it? What can we teach our patients? And what can I tell y'all right now? Because can stress cause you to do bad in school? Yes. So what can we do about it? We can try to do some things like yoga. Is yoga going to relax everybody? No, because I hate it, and I will not relax if I go to yoga. So we want to help our patients find something. Coffee. What about coffee? Does caffeine wire some people up? Y'all don't drink those energy drinks. I know y'all do. They may not relax you, okay? Get enough, y'all look. Do y'all see that? If you don't know it by midnight, you ain't gonna learn it at 1 o'clock in the morning when you're bobbing off half asleep. Go to bed, okay? Plan your days, okay? Get sleep. This is important for, when we say exercise, it's mobility. Your patients and you need mobility. If you don't have it, things happen, okay? Mobility is good for your peristalsis. One of the first things we tell people that are constipated is what? Do a little walking, you know? It helps your peristalsis, helps your blood sugar, keeps you from getting blood clots, lowers your blood pressure, prevents obesity, all these things. This is a good cholesterol. Y'all know what this word means, angiogenesis? If I run or walk, I'm going to build new blood vessels in my heart and legs. I'll take all the blood vessels I can get. Because one of them gets clotted, got another one, okay? So what happens if you're this? And we can have a tendency to be this as a student, can't we? We can have a tendency. Some people don't. They don't take the time to study. But say we do study all the time. Then these are the effects of immobility I want y'all to know. You do need to know them. Because we worry about this with our patients. They're too long, and then suddenly they have orders now they can get up to go to the bathroom. Are they as strong as they used to be? Could they fall? Yeah. So it's bad for my patients. Atrophy. This means your blood pressure lowers when you get up suddenly. Your heart's not in good shape. You can't take a deep breath. What happens if you can't take good deep breaths? When your patient's in the bed all the time not taking good deep breaths. Pneumonia. They can get pneumonia. So not taking good breaths. Your bones break down. Kidney stones. Constipation. Infection. Pressure injury from not moving. Y'all, moving is so important, even if it's just walking to the bathroom for your patient. These are some things that we do to combat immobility in our patients. We can do range of motion with them. We can get them up if they're allowed and help them walk. PT, we order physical therapy. And all. Y'all, what is something I was going to? Isometric exercise is sort of like Pure Bar or something where you can teach them to say maybe they're so weak all they can do is just kind of push their calf into the bed and flex their foot. As long as they're doing something. Y'all, this little thing right here, y'all need to blaze that in your mind because every nurse kind of knows it. If somebody is not able to move, and we have to turn them or position them, it's every 2 hours is like the hallmark turning. Every 2 hours at least. Could I turn them more than that if I felt like they needed it? Yes, but positioning every 2 hours. Why is that? If I'm laying on my hip for 4 hours with no movement, what am I pounding on right here? A bone right here. And that bone is digging into the mattress for just digging. What am I going to have? Pressure injury from what? Ischemia. Lack of blood flow in my cells and my skin is going to start breaking down. That's the pressure injury. That's why we move them to decrease that pressure. Y'all can, I'm not going to read this to you. These are the stages of pressure injuries from immobility. Y'all, it can go slam to the bone. Have I seen it? Yes. Have some of you maybe seen it? Maybe so. This slide is great because it gives you an idea about where you might need to watch for pressure injuries on your patient. Why are those little red dots where they are? What are those areas?
Prominent areas.
They're bony prominences, aren't they? Like my heels, my elbows, the back of my head. You know, all of those are areas where the skin, you've got a bone right under there, and so it can help with that pressure injury. And y'all, some of our patients can't move. Like y'all, I hear the chairs right now. I hear them creaking. You know what you're doing? You're taking the pressure off your butt. You're adjusting all the time so you don't get a pressure injury. But some of your patients can't do that. And so we have to do it for them. This is, ooh. Y'all, we might be in here till 12, but we're going to get through this cancer. Y'all know we got skills today. Not every Thursday, but most, and not always for 3 hours, but 3 today. All right. Woo! I love nursing school. Let's talk about cancer. Cancer's a horrible thing, isn't it? What What kind of cellular change is cancer of all those we talked about? What'd you say? Neoplasia, because neo means new. Plasia, growth, new growth. Okay. Do you have to memorize this slide? No. But what this slide is showing you is a normal cell cycle. It kind of knows when to go out and take a rest and quit dividing. And ooh, that cell doesn't look quite right. Let me stop, do some reconfiguring. I don't like the way that cell's looking. Okay, that's our normal process. This is cancer. Woo, woo. We don't care, we don't care, we don't care if we're abnormal. We don't care if somebody's telling us to do apoptosis. We don't care because we're just going to keep growing. That's what cancer does. Okay. So a tumor, a neoplasm, can be benign or malignant. If I told you you had to have one or the other, which one are you going for? Why? It's non-cancerous, but why do you want benign? Easier to remove. Usually it's not going to metastasize. What does that mean? Spread. Usually a benign tumor is encapsulated. It doesn't steal nutrients and blood flow from the normal tissue. The tissue still looks like the tissue of origin. But can benign tumors ever be bad? Why could they? It depends on where they are. Like if I had a benign tumor in my head, and it was growing really fast, and it's not going to spread anywhere, but it's in my head, and now it's the size of a baseball. Am I going to be in trouble? I am, because there's really nowhere to go, so I'm going to have pressure. Or what if I had a tumor pressing on my trachea? Could it cut off my airway, a benign tumor? But typically, the benign tumor does not have lethal consequences to the host. But cancer does, right? It didn't listen. It grows fast. It looks different. So if I had a breast cancer, okay, those breast cancer cells are going to start to have a word called anaplasia. Anaplasia. And what that means is they are starting not to look like breast cells anymore. They're different. They're nothing like their tissue of origin. They're not acting right. So we stage it or grade it by the degree of anaplasia. How much do they not look like breast cells? Okay, it's still a breast cell, but it's not right. Oh, look at this. They're hungry, so they take over. They compete for blood, nutrients. They're just stealing from their neighbors, cancer cells, cancerous tumors. They grow fast. Some of them have a genetic link. What this means is your body has proto-oncogens that try to tell cells to slow down a little bit, slow down a little bit, slow down a little bit, but cancer cells don't listen. Tumor suppressor genes that are supposed to keep tumors from growing, they might be faulty. So all of these things start happening. Faulty apoptosis could happen. So this is something that I think you need to know. See this, what's the suffix? End of a word, oma. If oma is at the end of a word, it might be benign, like lipoma. We know that lip means fat or lipid. So lipoma is a little fatty, just a little fat. Okay, that's not bad, is it? An adenoma would be a benign tumor of maybe the breast. You could have an adenoma. So oma's good, except why do we do this in medicine? I don't know. But we're like, okay, omas are good, but let's really trick everybody up because a melanoma is bad. Skin cancer can be bad. hepatoma, lymphoma, those are bad if they have oma at the end. Why do we do that? I'm not sure. And then we've got leukemia. It doesn't fit anything. If it's malignant, it's gonna have carcinoma or sarcoma on the end, okay? Like adenocarcinoma would be probably like a breast tumor. Osteosarcoma, what do you think that would be? Osteo means bone, sarcoma. You've got a bone cancer, okay? So carcinoma and sarcoma is cancer. This is kind of just what I said again. Benign versus malignant. Look at this thing they do too. They secrete inappropriate enzymes. They secrete things that make our immune system not work. Who has known somebody with cancer? Or everybody, right? By the time you're in your 60 to 79-year-old age range, 1 in 3 men and 1 in 5 women will experience cancer. It's a lot, isn't it? 90% of cancers are caused by chemicals, one of those things being like cigarettes and toxins like that. About 5% radiation, and about 5% is viruses and inflammation. Like that chronic inflammation from GERD that caused that Barrett's esophagus, that could cause esophageal cancer. But most of it is from things in our environment or things that we take in, etc. Just more about cancer cells not obeying the rules, and I've got some little videos that we don't have time for. And what did we say the word, what does it mean when it travels? Metastasis. That's dreaded. That is the dreaded thing about cancer, because that means it might have started in my breast, and now it's in my lungs or my brain. That's kind of where breast cancer likes to go. Did y'all know that? They kind of have certain target areas. Breast cancer tends to brain and lungs. Okay. More men than women. Leading cause of death behind heart disease. We talked about most cancers are chemical, 60%. 90%. So a lot of that is cigarette smoke and things in the environment. The most significant risk factor is age, because what I say about 60 to 79, 1 in 3 women and 1 in 5 men, the older you get, the more immunocompromised you are. Let me tell you what that word, if you're immunocompetent, what does that mean? Competent is good, right? Immunocompetence, being good with your immune system, decreases with age. So your immune system sees cancer cells out there, and it gobbles them up, gets rid of them, fights them all the time. But the older you get, you're not as able to fight that. So age is a big risk factor. Smoking. Y'all, we eat wrong, don't we? Too much eating and drinking and not water. And lack of exercise and those kind of things. Lack of antioxidants, obesity, all these things are risk factors, okay? That made me think of something that I forgot to tell y'all earlier about disease processes. So in America, we eat too much, we drink too much, and we don't get enough exercise. And so that's where our disease processes come from. In developing countries, it's usually nutrition and infection, correct? And since we're doing hand hygiene next week, what do you think is the main thing that causes hospital-acquired infections in the hospital? Lack of good hand washing. So we're going to do that. We have over 2 million HAIs in this country every year, and 90,000 of those people die. 90,000 people die from a hospital-acquired infection. How many people are on this campus? 15,000? That's like 5 or 6 of these campuses just get wiped out every year from hospital-acquired infections. And some of it is people not washing their hands. Okay, like I said, your immune system is constantly looking around for stuff and it attacks it. The older you get, the less that's going to work. Okay? We talked about that already. Viruses can cause cancer. Y'all know that? Like cervical cancer, what's that caused by? HPV. Epstein-Barr viruses cause a certain type of lymphoma. Okay, this is what you need to know on this one. That y'all, you know what a tumor marker is? It's a lab test, a lab draw, just like we've already talked about, okay? So these are some lab draws that you can do. A CEA, an alpha-fetoprotein, a PSA, all of these are drug tests, blood tests to screen for cancer, okay? You don't have to memorize which one, which lab test goes with which type of cancer, but we can do these. What would this be if I found prostate cancer in somebody? What type of prevention would that be? Secondary. Good. Papa-Nicolau test, a pap smear, can detect cervical cancer, breast cancer, mammograms, etc. Do y'all know what this stands for? You know what that stands for. If you didn't know when you were studying, you would look it up. It stands for digital rectal exam. Digital, like your finger's a digit. Digital rectal exam. Prostate specific antigen. This is fecal occult blood test. We're looking for blood in the poop. You don't have to learn the ages of these things, but it isn't like people at 40 usually begin a mammogram, unless they have a genetic thing, like the BRCA gene. Colonoscopy usually at 45, but look at this one right here. Is everybody in here at least 20? Every now and then I've got a baby in here that's 18 or 19. But everybody at least 20, should you get health exams? Yes, but some of you may not even have a doctor. Why? Because you're healthy and young. But health exams are very important. Okay, y'all, I know what time it is. We're hurrying. Thinking about metastasis, y'all, it's almost a miracle when something can metastasize. About 1 in 10,000 cells can make it. Because what they have to do is get out of the tissue of origin somehow, get into the bloodstream or lymphatics somehow, survive the immune system attacking it, get out of the bloodstream or the lymphatics, get into the new tissue, steal blood vessels, eat all the nutrients up, and start growing. So it's a process to metastasize. But how many cells does it take? 1. And then what does it start doing? All that fast growing business. Okay, we do need to know this. So we're going to look, what does histologic mean? We're looking at it under the microscope. And we're saying, man, her breast tumor does not look anything like breast tissue. It's got a high degree of anaplasia. That's a class 4. Which one's worse, you think, 3 or 4? 4. And then we're going to say, has it spread? And this is a method that we do it, y'all. Make sure you learn this, okay? TNM. How big is the tumor? Has it spread to the lymph nodes? Why do I care if it's in a lymph node? Because it's going to spread through the lymphatic system now. So I want the lymph nodes clear, right? Hopefully. And then, has it spread? So the TNM classification system is important. This is just to show you what all a cell has to do to be able to get out of here and start a new tumor here. We could do PET scans and CT scans. PET scan stands for positron emissions tomography. You don't have to really know that, but it shows you, you know, with a CT scan, you can see densities, but this can show like processes, physiological processes going on, and it can show tumors. All right, important slide, important, because now we're talking about real people. We're talking about somebody you're looking at, or you know. What can it do to the person's body? Number one, if I told y'all you had cancer right now, what would the first thing that happened to you? I'd be scared. Would you? Fear of death, fear of pain. Cancer can be asymptomatic at first. What does that word mean? No symptoms. Have you ever heard of anybody that they had no symptoms and then all of a sudden they went to the doctor and they had 2 weeks to live because they just started having a headache? But there was something going on before that. Pain from what? Pain can be from the tumor itself growing and pressing on structures. Oh, bone cancer, very painful. Or pain from the treatment. I had to get a port put in. I had to have surgery, you know. Pain from the treatment itself. Cachexia. Y'all say that word. Cachexia. You know what that means? Have you ever seen anybody with cancer and they're just so skinny and withered away? Their muscles are kind of gone. You know why? Because that cancer, remember how fast it's growing? It's taking everybody's nutrients. It's a really high metabolic state, and the people need a lot of calories. But who's hungry when they're getting chemo? You know, they're not hungry, they're nauseated, they're not eating, but that cancer is still wanting all that nutrition, and so they waste away. That's cachexia. Immune suppression and infection. So something that may not have given you an infection before, your immune system is so weak that you get sick when you wouldn't have gotten sick before. You ever seen people walking around? Of course you have, because y'all are in the COVID people, but before that, people wearing a mask when they went somewhere, they might have had cancer, and they were worried about getting an infection because they're compromised. Their immune system is compromised. Their bone marrow is suppressed. Oh, here's some words we gotta learn. What does leuco mean? White. Penia, not enough. You know what that means? Their white blood cell count that protects from infection is low. Their bone marrow is suppressed either from chemo, radiation, or the effects of the cancer. So if my white count's low and I'm immunocompromised, what are you worried about with me? You're worried. A lot of people with cancer die from an infection before they die from cancer, okay? Thrombocytopenia, that's a big word. You know what that means? We know we got not enough of something. Penia, right? Platelets. Thrombocytopenia is low platelet count. So if I have a low platelet count, I wonder what's going to happen to me. Do y'all know yet? You're going to learn next week. Y'all can impress Dr. Wright if you tell her. You're going to be susceptible to bleeding. You're going to be susceptible to bleeding. So if I fall and bump my head, I could have a brain bleed with thrombocytopenia. And then anemia. What kind of cells am I low in there? Red blood cells. What's their job? To carry what? Oxygen. Y'all, I'm going to be pale, tired. I might even be short of breath because I don't have enough oxygen. We talked about opportunistic infections. That's infection that I shouldn't get. And then, y'all have seen people with their hair falling out? You know why? Chemo. Because you know what chemo attacks? It's not careful. It attacks rapidly dividing cells. All of them. It is not selective. So my hair grows, your hair multiplies fast. So your hair's going to fall out with certain chemos. You're nauseated because your intestinal lining kind of reproduces fast, and so they're nauseated and vomiting. That's cachexia. How do we treat it? All kinds of ways. Hey, if the tumor is like localized, meaning it hadn't spread anywhere yet, maybe we can get it. And then what are we checking around it to make sure it hadn't spread to the lymph nodes? And we also want to make sure the margins are clear, because we don't want to leave any cells, do we? Because what could those cells do? They could metastasize and spread. So we can give chemo, radiation. We've talked about stem cells. We're harnessing the immune system, where some of these immune medicines we give people can target cancer cells specifically instead of being generalized like some of the chemos that we give. Early detection is best. What kind of prevention is that? Early detection? Secondary. Right? Wonder why it's best to find it early. It don't have time to spread, right? Okay, get it early. So how are we going to do that? What do we teach our patients? You got to have, like if I'm 40, I told you didn't have to know the numbers, but 40-ish, a female, hey, mammograms every year, self-breast exams. Men can do testicular exams. Go for your regular checkups. All of these things. There's even CT scans people can get for if they've smoked. So y'all probably need to know these, I would think. Caution, signs of cancer. Why do you need to know these? To teach your patients. Y'all, we're teachers. Teach your patients for you. To teach you, too. Oh, I'm just going to tell y'all something. And don't feel like you're not normal. When we start talking about some of these diseases, you're going to think you have them. Okay? A lot of times students say, I've got that same thing. And you might, but typically you don't. Okay. Changes in bladder habits, sore that doesn't heal, unusual bleeding, thickening, indigestion, changes in a water mold, coughing, you start to lose weight, and you have anemia. Cancer signs in children. Whew, we're almost done. Let's answer this question. Y'all pay good attention today. Y'all don't have to pack up just yet. Y'all can start zipping in a minute. You're not going to say that much time zipping backpacks. Characteristics of a malignant tumor. This is how you should take an exam, soft exam. What can we cross out? A, because encapsulated means it's like in a little lump. Localized, let's cross that out. Can we cross that out? It steals blood vessels. Vascularity means vessels. But it has a less degree of differentiation, meaning it doesn't look like the tissue of origin. So make sure you know that terminology. Lesser degree of differentiation. All right, so look.